Next speaker is Dr. Sindhu NM. She is associate professor in Government Medical College Ernakulam, and she'll be speaking about the corneal and the scleral injuries.
Good afternoon, everybody. My talk is on management of corneal scleral injuries. Trauma is the second major cause of corneal blindness. It mainly affects the young adults. It not only affects the vision of the patient, but also it's a psychological and economic trauma to the patient and their families. Whenever you get a patient like this with an injury to the cornea involving with or without sclera, all the life-threatening injuries as in polytrauma to be noted, vitals of the patients to be documented, and documentation of the visual acuity after a detailed ocular examination under slit lamp is to be done. The extent of the corneal injury, extent of the trauma and zone should be written, and you should come to a diagnosis depending upon as per the Birmingham eye trauma terminology system, and you can prognosticate the condition by ocular trauma score, and everything should be documented in detail in view of medical legal purposes. The investigations includes X-ray orbit, CT scan to rule out an intraocular foreign body, B scan though it's not done immediately at the time of trauma, which will give a detailed idea about the posterior segment. You should do it very gently with a copious amount of gels. Anterior segment OCT is a non-contact investigation to assess the depth of corneal lacerations. A tetanus prophylaxis is to be done, and systemic antibiotics should be started immediately with third broad spectrum antibiotics to prevent the secondary infections and also to prevent endophthalmitis. Coming to the corneal wound management, all non-penetrating injuries should be treated with bandage contact lens along with prophylactic antibiotic and cycloplegic, and simple full thickness corneal injuries less than 2 mm if it is self-sealing non-displaced can be managed with bandage contact lens and antibiotics. Small injuries, if it is non-self-sealing or stellate or any tissue loss, you can apply glue along with the bandage contact lens. A large wound more than 2 mm or small wounds in non-cooperative patients, children or mentally challenged individuals needs definitive therapy. General anesthesia is the preferred choice, but if it is not possible, you can do a surgery under local anesthesia with a good facial block. Always avoid lid speculum. A good exposure can be attained by lid sutures. A culture should be taken from the margins of the wound if they are presenting with any corneal infiltrations. The goals of the corneal wound repairing primary aim is to attain a complete watertight closure of the globe with the restoration of the structural integrity. And the secondary aims include avoidance of uveal tissue or vitreous incarceration in the wound, removal of necrotic tissue, disrupted lens or any foreign bodies. The corneal suturing principles always establish a normal contour, secure the limbus first if the injury is involving the limbus. Try to put a paracentesis, although it is very difficult to put in the soft globe with flat AC. It will help in good maneuvering of the instruments and to sweep the iris tissue through in iris prolapse. It will help to keep the AC formed with BSS. The suture materials, monofilamentous suture with low tissue reactivity, mainly commonly 10-0 nylon or polypropylene are the choices. Needle should be spatulated, and the depth of the corneal sutures must be 80 to 90% deep in the stroma, and it should be equal depth on both sides of the wound. As in the picture 1 shows, avoid full thickness sutures which can act as a conduit for microbial invasion, and when you get an oblique wound as in picture 3, always try to pass the needle equidistant from the wound edges in relation to the posterior surface of the corneal laceration. Otherwise, if you take suture bite in relation to the anterior surface, there can be overriding of the posterior part and wound gaping can occur. The suture passes should be 1.5 to 2 mm in total length. It should be equally spaced on either side of the wound, and try to enter the perpendicular to the corneal surface and should be passed in a single throw to avoid multiple entries. As the stellate wounds, like in picture 4, when you get it, you close the apex of the wound with a horizontal matrix suture or a purse string suture and take the other wounds as linear stems and close it as a linear wound. The second picture shows the techniques to avoid minimize the astigmatism. That is called Rossi-Hayes technique of corneal suturing. The corneal laceration should be closed initially with long, shallow, tight sutures with more compression in the corneal periphery. When you come closer to the center, take shorter, deeper, and more widely spaced and minimally compressive suture to avoid steep flattening of the central cornea and to reduce the scarring and astigmatism. The knots should be tight, trimmed, and short and buried in the stroma. Over-tightening of the suture should be tightened enough to avoid any leaky wound. Over-tightening can create astigmatism, but in the post-operative period, you can remove 1 or 2 sutures to reduce the astigmatism. Avoid excising corneal tissue wherever it's possible. Explore the sclera if there are any limbal involvement or any subconjunctival hemorrhage or chemosis. And in wounds like this picture, try to put the first suture at the limbus, and then the next suture should be at the apex of the wounds and close the rest of the area. And any iris tissue prolapse should be reposited, or and if there is no signs of infection and presentation is less than 24 hours. And before repositioning, clean the surface of the iris and remove the epithelium formed before repositioning. Always excise the iris tissue if there is any signs of necrosis, maceration, or infection, or the presentation is more than 24 hours. You should suspect scleral injuries when there is a visual acuity is less than very less or soft eyeball, shallow anterior chamber or blood-filled anterior chamber, in media opacity or intense periocular hemorrhage. Site of scleral injury is more common at the areas of the thin areas like limbus, muscle insertion. Occult scleral wound should be suspected and exploration should be done with 360-degree peritomy. Scleral wounds should be closed as the close as you go technique, that you should start at the beginning of the recognizable landmark like limbus and suture anteriorly and go posteriorly. The extraocular muscle insertions, if your wound is going under it, you can put a traction suture and inspect it well and complete the suture. Sometimes you may need to disinsert the muscle, and after suturing you can reinsert it. Tight closure prevents the fibrovascular proliferation, and interrupted sutures to be put. Non-absorbable sutures 80 or 90 nylon. Always reposit the prolapsed uveal tissue. If vitreous is present, it should be amputated at the scleral surface. Prolapsed retinal tissue is generally reposited. Always seek vitreoretinal consultation or intervention if needed. And management with the topical systemic antibiotics and systemic steroids to prevent sympathetic ophthalmia. To conclude, prompt treatment and management with established principles can yield the best visual outcome and minimize the risk of developing vision-threatening complication. Thank you for your patient listening.
Thank you, Sindhu, for that meticulous presentation.